Hi, everyone. I am Molly Gamble, Vice President Editorial at Becker's Healthcare. Welcome to Innovating for the Future of Surgery, Leveraging Data to Drive Actionable Insights. Today, we have the opportunity to hear from three leaders in nursing, finance, and operations from San Diego-based Sharp Healthcare: Christopher Walker, Susan Stone, and Fahd Ben-Jalil. Today, we'll discuss innovation in the future of surgery. Before I ask our guests to introduce themselves, let me share a bit more about Sharp Healthcare with you. Sharp is a not-for-profit regional health system in San Diego. With nearly 2,700 affiliated physicians, Sharp is made up of 4 acute care hospitals, 3 specialty hospitals, 3 affiliated medical groups, and a health plan. Sharp is committed to innovation, having recently opened its Sharp Previs Innovation and Education Center. With that, I'd like to welcome our guests, Chris, Susan, and Fahd. Thank you so much for taking some time to join me today. Let me turn it over to you to take a moment to introduce yourselves and share a bit more about your background. Chris, can I turn to you first?
Absolutely. Thank you. And thank you for having us. I really appreciate it. So Chris Walker, I am the Chief Operating Officer, as I said. I've been at Sharp for 23 years. I came as a traveler passing through town. I never made it out. I've done 13 different jobs. I've worked very closely with the 2 of my colleagues that are on this call over the years, and we continue to work very closely. I've done a lot of different jobs along the way, from bedside nurse to chief nursing officer to chief operating officer of 2 of our campuses. So, and now I'm over the Sharp Memorial Hospital, which is one of the original hospital that was part of the original Sharp brand that kind of started it all back in the early 1960s. So pleased to be here, and I appreciate it.
Chris, judging by the background, I can see why a traveler would get allured to Sharp and stay for 23 years. So thank you very much for joining us.
That is what did it.
Susan, can I turn to you next?
My name is Susan Stone. I'm the Senior Vice President at Sharp Healthcare for Health System Operations and the System Chief Nursing Executive. I've been at Sharp Healthcare for 37 years, and throughout that journey, starting as a nursing assistant, working in nearly every nursing position that can exist, and I'm proud to have been the Sharp Coronado Hospital CEO at the time that we started our robotic program of excellence.
So much, Susan. Fahd, we've got already 60 years with Sharp on the screen. What would you add?
Well, I'm not going to add as many years, but my name is Fahd Ben-Jalil, and I'm the Chief Financial and Operating Officer at Sharp Coronado Hospital. I've been with Sharp for a little over 13 years, started as a financial analyst and worked my way up to CFO and then CFO, COO, currently at the current hospital. I'm very excited to be here in partnership with Chris and Susan. We worked very closely together in starting our program here at Sharp Coronado Hospital, and really excited to share more information about it.
That's great. Wonderful. Thank you, each of you, for joining us. 73 years of shared tenure with the organization and history. That's really remarkable. As you so wonderfully illustrate with your opening remarks, at Sharp Healthcare, you have a big vision and a big mission. You are relying on the mission to constantly find ways to stay at the forefront of improving patient care by transforming the health experience while being the best place to work and practice medicine. These are lofty goals. What has been your outlook on innovation and strategy to make progress on these important goals? Susan, let me hear from you first.
I think at the core of innovation is that combination of high technology, bringing in the best of technology that can advance your clinical care teams, whether it's surgery, procedural, clinical care at the bedside, really providing the best in that equipment technology and providing your clinical care team to equip them for the best possible outcomes. For this particular program, we really felt strongly that this was the best in clinical equipment and innovation to help our team produce the best in clinical outcomes. Our surgeons and our team members were our team members and our surgeons were absolutely adamant that this was the best in the surgical instrumentation at the time. And that, to me, is the core of innovation, combining those things together.
Chris, what would you add to what Susan shared?
Well, when I think about robotics, it popped up in the early 2000s, and it was going to be a fad as far as everyone thought. And here we are 20 years later, and it's really become a primary surgical tool. And where maybe it's not even innovative anymore to launch a robotic assisted surgical program. However, there's been lots of iterations along the way that's continued to make it cutting edge. The advancement of many different specialties at Sharp Healthcare, we have 8 or 9, up to 9 subspecialties doing cases on the robotic platforms. It's really becoming a primary surgical tool, but it's allowing us to deliver better care. And when you think about our vision to be in the best place to work, practice medicine, and receive care, our robotic strategy kind of fits along with that. We want to give our surgeons the tools that give them the most confidence, deliver the best outcomes so that our patients have excellent clinical care, but the shortest hospitalizations, the fastest return to recovery, and really ultimately back to their life as soon as possible. And our clinical staff have enjoyed being part of that innovation as well. And I think that's one of the things that got me here at Sharp Healthcare. When I thought I was only cut out to work in academic settings, and I was just going to move through town. And I got stuck here because I saw that this place was really committed to the highest level of clinical care delivery, with strong partnership between the executive, the physicians, and the frontline operations. And it's really those 3 pillars that have really carried us for many years in a lot of different service lines and through a lot of different challenges. And it's going to be what drives us into the future as well.
So much of our conversation today is going to be forward looking as we discuss the future. But Susan, I wanted to turn back to you because you had mentioned, and just to spend a bit of time in the rear view, if you will let me, you had mentioned that the surgical team was adamant about robotics. I'm curious, was the buy-in always existent, or did it take some work between the executive team, the clinicians, the clinical teams, and the operational teams to build and establish full buy-in?
Initially within Sharp Healthcare, there was some buy-in for super subspecialty urology and GYN at the tertiary care facility, and we had a small amount of robots. We were approached at Coronado about a unique business case. We were building out some new surgical suites, and we were approached by 2 general surgeons who had been trained on these robots, and they wanted to build a business case that this instrumentation could prove to be the best for general surgery and more of the less tertiary types of cases, cholecystectomy, and hernia cases, appendectomies. And so it was really a departure from the system's philosophy to sanction an instrument of this kind, which was thought to be very high end and would increase cost per case. So the 3 of us worked together to build a business case around proving that the robotic technology really was the instrument of the future that could produce the better outcomes at equivalent or less price. And that's really what we get to in healthcare, is figuring out how we can work smarter and use the best instrumentation, get the best outcomes, and then have a shorter length of stay, better patient satisfaction, greater physician satisfaction. So we built a business case around that, a proposal. It did take buy-in from the very senior leaders of the organization. I think they thought that we would fail. This was being used as a way for them to get more robots at the flagship facility, that perhaps the general surgeons would not come, we wouldn't get the volume, and that we wouldn't be able to prove our business case. From our own hospital board and from the foundation board, because we did have to have it philanthropically funded, I'm pleased to say that our business case was unanimously supported. And our surgeons and our team members and our foundation and our board were 100% behind this project. And for us, it was very important to lead with these physicians who approached us. For those executives who are watching this webinar, the challenge to us was, get a robot here within 30 days and we will come to your facility. And that's just not how healthcare works. To get $1.3 million piece of equipment in 30 days, but I'm pleased to say that this team did that. We got the robot on the 30th day, and the surgeons did come, and our story's kind of a wonderful story that we have been able to prove that business case and really have changed the framework of how people view the robotic instrumentation today.
Terrific. Fad, I'm going to turn to you next. We're talking about how Sharp, there was some healthy skepticism in the beginning, but with some time, some change management, some persuasion, and a robot delivered within 30 days, a corner was turned. I wanted to check in with you, Fad, because you bring a really important perspective to this conversation. Within the system, and specifically the Da Vinci program, you all are making this connection between innovation and superior quality outcomes. And when looking at the clinical outcomes, can you talk about what has helped with some of the biggest challenges executives are facing with financial pressure, staffing being top of mind at every hospital and health system right now? I would love, Fad, to hear about what has helped the most in terms of making these decisions with those pressures in mind.
Thank you, Molly. I think the reality of it is our industry is faced today with a tremendous amount of challenges. Post-COVID, we are still struggling with staffing. We have declining reimbursements. We have increasing expenses. So really focusing on how can we reduce cost of care, or how can we increase revenue by growing programs is very important from my perspective. So in looking at the Da Vinci program, I think having better clinical outcomes will eventually results in downstream savings. So shorter length of stay, less readmission, less blood loss, fewer SSIs, as well as OR time, in which the surgeons, the more cases they do with the robot, the more comfortable they are doing those cases, resulting in less time on the console, resulting in more throughput. So stepping back from the old view of, yes, this is going to increase my cost per case directly by adding the disposable costs, etc. However, when you look at the globality of the cost per case in looking at the whole downstream, you will definitely see some reduction. So reduction in PACU time equals cost savings. The other component, as I mentioned, is the time on the console as well. So when we started this program at Coronado, we had built the pro forma for the X robot to be paid off within 2 years. And I'm happy to share that we paid it off within 10 months. And that's the result of having those surgeons actually coming, doing those surgeries, helping our teams grow, learning how to have a better turnover times in the OR, and really providing the best patient experience possible while still sending patients home the same day. So what we also looked at is we grew, the confidence and diversity of the cases that helped us transform the program. Our program initially at Sharp Coronado was built in the Pain Family Outpatient Pavilion, and it provided a new and innovative experience for the patients, physicians, and staff. Now, when we look at on the acute care side, or not the acute care side, but more complex cases, we are seeing that the setup of the room is a lot easier with the robotic. Less trays are set up as well, and all that at the end of the day saves money and decrease the cost of care.
One of the things that we, one of the things that we really learned early on, we attended the Intuitive 360 session, and we heard from others in the industry who were using this robotic technology, and we learned from them. And I think that really kind of set us on fire for this. I remember sitting with Chris in one of the sessions, and we were learning about the Robotic Center of Excellence and how you could frame up your program to really be the best in the industry. And on that day, I can remember us having a conversation about, this is what we want to be. We want to be the best in the industry. We want to be the destination of choice. And I think as we incrementally made progress on our business case and we're bearing out the assumptions in our case, all of us just getting more and more excited about the potential of this technology.
I wanted to just make sure I understand clearly something that you mentioned, the projection of paying off the robot within its first 2 years of utilization, right? And it actually was paid off in its first 10 months.
That's correct.
Okay.
Yes.
Remarkable. Wow.
And this was all new business to this facility, which is really hard to find these days.
Yep. And then just to check in with you too, Susan, and Chris, feel free to weigh in here as well. But Fahd, you had mentioned these downstream and long-term cost savings opportunities with shorter length of stay, fewer readmissions, less blood loss, fewer surgical site infections. Are there any others that your colleagues would add to this running tally?
I mean, you got the big ones. I think ICU utilization is a big one. If you do things minimally invasive, you're going to reduce overall cost of care. I mean, a lot of what we really had to do is figure out where we have to reduce the cost of care. But, you know, blood transfusion is a cost and a quality metric. Length of stay is a cost and a quality metric. Reoperations, readmissions, and surgical site infections, those are all pieces. And then you get to the more tangible, you know, episodic pain associated with bigger scars, longer healing. All of those things drive costs, drive recidivism, and at the end of the day is not the patient experience we really wanted to deliver.
Yeah, I think one of the other things that we really saw was we went from a open and laparoscopic based procedure with overnight stays for the majority of the patients. And now we're at a same day discharge as our reality for 99% of the patients, just because we are comfortable that the patients are going to go home and they're not going to have any problems. So when you can reduce that and convert to an outpatient base instead of having an observation overnight stay, that's a huge savings overall. And you're getting better outcomes, your patient's more comfortable at home, you can manage the side effects, and the patients report to us and their surgeons how much better they feel as compared to the reports that their patients were giving the surgeons prior to this program.
The other thing that I'd like to add, Molly, to this conversation is also when we're looking at length of stay, quite often we think of it as inpatient length of stay, right? But when you're also looking at an outpatient case and how much the throughput helps in increasing volume, that's also length of stay, and that's also a cost saving. So I'll give you an example of, I observed a case a couple months ago, and I observed the case from beginning to end, was there when the patient received the tab blocks in our pre-op area, went into the OR, did the procedure. They actually asked me to drape the robot, which I was a little bit anxious about because I knew how much those things cost. But after all, I did it and saw the procedure through, helped sat with the patient in PACU for the time he was there, and then help the patient to the car. So I was able to see from beginning to end what that patient experience looked like, and also the time that it would take. Now, I wasn't there to identify inefficiencies or find ways to save money, but I was there to observe the actual case and really understand that whole robotics case and what it takes to get a successful case through. So I think a lot of it has to do with really pausing and looking at length of stay, not only from an inpatient side, but also from an outpatient side, which equals throughput, more volume.
Mm-hmm. In fact, before we move on, I want to stay with you for one beat more. In your role as CFO, can you talk about the data or evidence that you have found the most essential in telling you and informing you that this strategy would be financially viable for Sharp? You know, we're talking a lot about a lot of the indicators, a lot of the mile markers. Can you, anything else you would add just about data and evidence for any other CFOs who are joining us today?
I think it's trusting in the data that comes from Intuitive. I'll speak for myself as a CFO. Originally, when I hear data coming from a vendor, I am always reluctant to trust in that data. However, the data that comes from Intuitive is data that belongs to us, which is based on our robot utilization. And being able to look at that data, also working alongside our data teams to incorporate other data metrics from our own data warehouse into this, and having it in dashboards and reports allows us to see a reduction in PACU time, as I mentioned, from the beginning of the program, or even consult time. So one of the charts that I love to look at is to see the consult time for our surgeons. And we can see that when we implemented this project at the beginning to where we are now, there was a 35% reduction in the time each surgeon spent on the console. So the more cases they do, the more confident they are. And so therefore, the less time on the console they need. Now, from our team's perspective or operational team's perspective, there is also that confidence in the more cases you do, the more comfortable the techs are and the nurses are, and therefore they can have a room turnover pretty quickly, which also ends up providing a better throughput for our patients and increased volumes.
And Molly, I just would like to add, like, we're kind of telling the story in a time warp because I guess that's how life feels these days. Like we started this project and we had such a positive, like, early success when we started this at Coronado. And then when my job transitioned back to the Metro campus, we had a lot of things as a system to address. We were still kind of generally practicing as people that had robots, but not a robotic program. We didn't organize as a service line. We didn't engage all the system resources and collegially across the aisle between all the different ORs and all the physician leaders to really drive it in the right direction. And we really had to change it philosophically, and Pod nailed it. Like, one, we had to stop acting like the vendor was the enemy, that there could be some learnings and some opportunities to work with them. There was information and free services that they made available that were helpful for efficiency, for competency, for driving quality and physician support. And when we stopped fighting and we started realizing that through partnerships and collaborations we could do more, then we started to put the strategies around how do we look at data? How do we look at data with Intuitive? How do we look at data internally more real time? How do we create dashboards? How do we, for our operational teams, how do we create report cards for our physicians so that they can evaluate themselves and find ways to course correct? How do we look at variation in costs across providers to see, is there opportunities to standardize and drive costs down? Even if we felt like we were still doing good on a margin basis, could we find more margin? Because there's always a variety of payer mix along the way. And it wasn't until we started to think that way that we really started to scale. And now we were able to go back and look at like 8 years of data now, and we could look at ICU utilization between robotic and open. And it's a 4% difference, which is worth a couple $1 million just in certain populations. I think that one, and then length of stay alone was worth $20+ million over that period of time when you compared open versus robotic. And so we committed, all over and over again about how are we going to continue to move in this path to drive minimally invasive surgical strategies as a priority for our organization, robotics leading the way, because that is the tool that physicians are coming out of fellowships most prepared to use. And it gives them the best outcomes, it gives our patients the best care, and it's translating into financial outcomes. Just in one, I think it was the hysterectomies, I'm looking at a data point that I had, was blood transfusions were 8% less in robotics compared to, in hysterectomies compared to ones that were done open. Like that translates into $500,000 just on blood transfusions. So if you just think about it from a cost, it's good. If you start thinking about it from a quality, it's an imperative. And we have several different metrics that we've been able to put the dollars to establish the value proposition. Or why do we support robotics? People laugh at us when we tell them how many robots we have in the system, because we happen to have the most in Southern California and maybe all of California at this point. But that's because we believe and because it brings value to our patients.
I think one of the things that's very interesting about this case study is the way that the organization has strategically shared talent. So we all started with one small hospital that kind of influenced the greater organization. Originally, they were upset because the doctors were wanting to come to the smaller facility because we were embracing this technology and our program was growing. We had partnerships with doctors, we had an advisory council, we had open dialogue, and Intuitive was there sharing their data reports with them and us. And having Chris be then promoted to the larger flagship facility, it brought that knowledge, the program elements to the larger facility to say, we can do this. It just needs to be modified for a huge campus. We had 5 ORs. They have, how many do you have, Chris?
39. We have 39.
There you go. So you take it from the small site, which isn't typical of how large organizations work. It's typically that you have the flagship facility creating a program and then it's replicated at the outlying facilities. But this was a great example of how when you're innovative and you kind of do your homework, and Chris used to say, we have grit and we're scrappy. At Coronado, but we really are persistent and we're pursuit of excellence at no compromise. You know, all 3 of us really committed to the program to show that it was the best, and to see that Fuad's now the day-to-day operator of Coronado, and Chris is the day-to-day operator at a Memorial and Metro area, and I'm gone on to the corporate office. It's really how you share talent and you raise your organization overall.
So many valuable points you all just raised, and I feel like the passion is coming through from the screen about the program and about innovation. And you know, we established the groundwork. We talked about, we looked in the rear view a bit, as I had mentioned, but now let's look forward. You know, I'm curious to understand, as you've seen growth in robotics over the years, how did you really start to conceptualize the future of this technology versus laparoscopic? Chris, I love the line you had said, we were a group of people with a bunch of robots and we didn't have a program. We needed to firm up our strategy. That takes work and really great communication, talent sharing, like you mentioned, Susan. But I'm curious about, how did you dig deeper into understanding as a surgical modality where robotics is going and feel really confident about making further investments? What helped you make those choices?
Yeah, I mean, that's a great point. Like, even with maybe like a philosophical shift that we like to take credit for starting the wave, so to speak, kind of goes with my background. We really, to do what we really wanted to do, we could never obtain enough. We would never get the number of robots we needed to do what we really wanted to do. So we had to figure out a different strategy. And we were using, you know, we were going about it with a traditional capital acquisition model. And it really was like, that's like one robot, even for a big campus like mine, that's like one robot every few years. And we had it, when I got back to this campus in 2019, we had 5 robots on this campus, which was a lot for this campus at the time. But now we're at 13. And it would have taken me 20, 25 years to get 13 robotic assets. So I think that's through some creative partnerships and contracting with our Intuitive partners, coming up with creative acquisition models where we can operationalize the costs, which is another thing that if there's CFOs that want to understand how we did this, we kind of took a couple runs at this kind of capitalized or operational lease type model. And we finally said, we kind of came up with that there's no real downside to doing this, and there was a lot of upside. And it translated into thousands of more cases per year at our organizations, and not just transitioning open to robotic, which we fully believe in, but also true growth. We got surgeons coming from other organizations that want to practice here because we believe that robotic strategy is part of minimally invasive now, just like laparoscopic was evolutionary 30 years ago. robotics is that next stage, and we're getting out in front of it because we are aligning with our physicians. We are committed to driving the outcomes that we've been able to put the data behind to validate our, what was really just a philosophical belief is now conviction. And we have everyone believing us from top to bottom in the organization that robotics is good. It's good for Sharp Healthcare. It's good for San Diegans that want to get cared and get back to their lives. And so it was a major transition for us, and we wouldn't have been able to do it through traditional methodologies. And I think that's been great for Coronado to scale. You know, yes, we use philanthropy for a while. We've used other mechanisms, but at the end of the day, we needed a different approach that would allow us to scale. I would be still working with 6 specialties, but now we have 8 and 9 specialties using robotics. And I say and 9 because we're looking at starting transplant, renal transplant robotically. So that'll be our 9th subspecialty. But we started a minimally invasive cardiac program that I could not have taken up a robot because it would just take it away from all the other docs, and I would have infighting over access. And now I can grow programs. We can deliver better care across many specialties because robotic service line is not one service line. It's almost all the service lines, you know. So and that's the way we are thinking about this. And we're not thinking about it as executives. We're thinking about it as executives working closely with physicians and working closely with our operations, and then collaborating with our vendor partners who have been good to us and helping us really drive cost in the right direction, efficiency in the right direction, and at the end of the day, our outcomes in the right direction. You know, this is one of the observations that we've made. You know, we went from being, you know, a pretty significant amount of open surgery in our organization, and now that has changed. Like we're down to about 18% open surgery, and a lot of that is driven by trauma and other open cases that are really not addressable from a robotic approach. But even our minimally invasive, if you look at just the minimally invasive, it's up to really 82% of our total. 55% of that is robotic. And one of the things I've kind of contemplated about, how do we think about other cost reductions we can do? Right now, the way it works in our main OR and even in some of our outpatients, we just put laparoscopic towers in all those areas. And then when they reach end of life, we replace them. And then they seem to and I'm not even sure how much mileage we're putting on laparoscopic towers these days. And I'm beginning to start to look at what are the strategies to really think about what is the right technology in the standard OR setup. And maybe just automatically putting laparoscopic in every OR is maybe not the right path, that there is alternative strategies. And I've already started to do that. We've looked at some of our rooms where we needed to scale out additional robots. And I'm not putting laparoscopic towers in there. And I'm going to be reevaluating every time it comes up. When it comes to end of life, I'm not just going to replace, because I don't think we're really getting the value out of our laparoscopic towers. And I do see the transition occurring. And there's ways to achieve that. And I envision in the next 5 or more years that it really is going to be most rooms have the robotic technology or some kind of advanced navigation. And the upside down and backward technology of laparoscopy is going to probably start to come to an end. And I do think that that's the future. And it's something that's going to happen.
Yeah, I think one of the other things is I have heard that there's not necessarily a belief in having a robot available 7/24, and that some docs in some organizations really struggle for that. But we have believed from early on that this is the best instrument for the best outcome regardless of time of day. So I think organizations just really need to consider this as part of the training that you have. You cross-train everybody. It's not a robotics team. Maybe in some specialties you do that, but general surgery, a surgical team needs to be able to do the general surgeries on a robot, and it shouldn't be considered just the small group of people that get trained on that. And I think that's a hurdle that people oftentimes get stuck on. And I think that's one of the draws that we've had, is that we do have that available to them. And some of the rooms, they get block time on the robot if they're willing to bring a certain number of cases.
Yeah.
So how can you really build a program around it? It's by volume, right? So what are the areas and what are the things the docs, and having that open dialogue with the docs, what is it you need for this program to grow? And that partnership just nurtures itself.
I would say over the last 4 years, like now robotic competency for OR nurses and techs is basic skills. Like it's no longer specialty. It's part of everything. It's a minimum requirement. You need to be competent on it because that's what we do. We do a lot of robotic surgery, and that allows us to, our robotic surgery, we don't go to open surgery when that 5 o'clock comes around and the night team comes on. The night team needs to be able to deliver that care, but the day team needs to be able to do it. And it also fits into just a broader, when I think of the robotic service line and the quintuple aim, I think about the latest edition with health equity. And if you think about it, people with the least access, maybe not the best insurers, they come through the ER, they often come after work, they come and they were getting open surgeries that were going to keep them out of work, probably more pain, more risk for complications. And if you had good insurance and you had good access to care, you were coming elective, you were going to get it during the daylight hours, you were going to get access to robotic or minimally invasive technology. And we really wanted to say that our teams and our equipment availability was not going to be the driver for what tool the physician uses for a patient care event. And so we thought that 24/7 access is critical to delivering equitable care to all patients, regardless of how they present to your hospital.
I think one thing I wanted to add to the conversation, and Chris alluded to this, is the creative model, the creative acquisition model that we currently have with Intuitive. To Chris's point, originally, it would have taken him 25 years to get all the robots that he has today. And for Coronado, it would have been impossible to get to where we are. We currently have 3 robots. And it's all about creating that access. To Chris's point and Susan's point, is creating that access to the surgeons, creating the access to our patients. But then it's quite difficult to do it in the old model with capital purchases. With the new creative acquisition model, our health system is as much at risk as Intuitive is at risk. And actually, it's even more, the risk is even more on the Intuitive side than on the Sharp Healthcare side. Because what happens with this model is they provide us with a robot. We have to do a minimum number of cases per quarter. But if we don't do those cases, we don't have anything to pay. There is no fine to pay. So in this model, we're paying on a per click, on a per use. So it is to everyone's benefit to increase volume, to create additional access, and also to provide the ability for all patients to have access to this robotic surgery model.
And Fad, as a CFO, did that model at first seem too good to be true at all? Were you almost waiting for the other foot to drop?
So when that originally happened, to be honest with you, I was like, this is crazy. This doesn't make any sense. Why would we pay for something that, why would I pay every time I use the robot when I can actually use a robot that I own, right? But at the same time I would have never been able to provide additional access or buy additional robots without this model, right? So it's finding that middle ground of utilizing the robots you own and the robots that we're using through this. But yes, it is a change in mindset. It is a change in culture. You're moving from a below the line expense, which would have been a depreciation expense, to now a purchase service expense. So yes, it's a totally different mindset. For other CFOs that I've talked to, they're like, well, how are you saving money? You are saving money in other components. I may increase my purchase services here, but I'm saving in length of stay, and I'm increasing my volume and giving access to my surgeons. So at the end of the day, it is a profitable endeavor, and it really helps our system in being in the forefront and having all those access to all these surgeons and attracting new talent, right? It's not only looking at the surgeons that we currently have, but by having additional access, you are attracting other surgeons that don't have access at other health systems in town.
I think the model gives us an opportunity as well to consider what other things could we do to drive costs down. So we were able to look at lower cost settings, so site of care strategy, and moving 2 robotic platforms to our outpatient pavilion so that we could decant some of those cases from our main OR. So get it out of the trauma, transplant, cardiovascular area and get it into a place where we can really do really what we were doing at Coronado and try to replicate that success. But by doing that, that was a very big, a major cost savings. That setting is far less costly than where we were doing many of these outpatient robotic cases in our main OR, and that was hugely successful. And if I didn't have this creative acquisition approach, I wouldn't have been able to even test that water because I would just needed it too much in the main ORs, and I wouldn't have been able to do that. And that's driving value to our capitated health plan, where we have 300,000 lives that we manage the full risk on. And it also helps in other areas by bringing value to other payers so that we can share with them that we can bring costs down, we can do more outpatient across the board, and we can keep patients out and get them back to work, get them back to paying their per member per month, approach. So.
This has been such an interesting and dynamic conversation. You've touched on so many different aspects of your program, from its origins to its early days to where it stands now to looking ahead. I wanted to make sure you each have an opportunity to share your final thoughts or any key takeaways that you would really like our audience to walk away with today. Susan, I'm going to turn to you first, then I'll check in with Chris and then Fahd.
I think that one of the key things I would share with an organization who's maybe considering where is their program is that you have to have courage and you have to be willing to fail, but you have to be willing to go into the innovation space and really pick your right partners. I mean, I'm just so grateful to Dr. David Greenblatt and Eric Ludke, who really were our key partners in this program, who believed as much as we did that this was going to be successful. 2 of the best surgeons, I believe, in the world, who do incredible things, who are now speaking on all of the things that we've learned, as are we. But then don't stop, right? Keep going. You know, we are going to be lifting off the hub technology, where doctors will have the ability to videotape their cases. They will be able to learn from what they've done. Oh, that case went really well. What did I do differently? They can share that technique with others. And then never stop evaluating. Don't stop at status quo. You always consider that this journey, you're on a long-term journey. You're not on a short journey. Always evaluate your data and do that alongside your surgeons. I think that's the key thing. Train your teams and let them do their amazing job. Hire the right people. Share your talent. It's just been an incredible journey and an honor to work with this team in this journey.
Chris, what would you add to Susan's remarks?
Well, I think she hit most of them. It kind of goes back to what I said earlier. It takes executive leadership, it takes physician leadership, and it takes operational leadership and commitment to pull all the pieces together. We got to drive efficiency. We got to be committed to driving costs down. But at the core of this, we take care of people, we take care of patients, and we want to make sure they get the best possible care. And if we can do the best possible care at the lowest costs, then you're winning the sometimes feeling like an unsolvable problem in healthcare, and the best part is like just the relationship change with our surgeons. It was always very positive as we built it at Coronado. It wasn't that way for me when I got here. It was really not positive at all. But because we've really worked together and shifted it, it's my favorite group of physicians to work with. We are doing so much good stuff, working together, sharing our story, presenting in conferences all over the country about our successes, and telling those stories only helps reinvigorate and re-energize us into continuing our mission to deliver great care. And we really want to be that best place to work, practice medicine, receive care, and continue what we've done for San Diego for the last, 75 years. I think it's been now, something like that.
Fahd, you're going to wind us down here with the final word.
I think both Chris and Susan summarized it pretty well. I think providing the best care at the lowest cost possible is the challenge that every single healthcare leader has. Now, if we can provide that and still provide a space where physicians and team members are excited to go to work every day, excited to learn new things, I think then you hit all of the right things. The one thing that I would close us up with is be open-minded, and this goes to my fellow CFOs out there. Be open-minded with the approach. It's what makes us better is not just looking at the direct components of it, but looking at the bigger, broader picture. So I would just say keep your eyes open and be open-minded.
Fahd, Susan, Chris, I want to thank each of you for your energy, your comments and insights today, your time. Learned a lot from you, and thank you for sharing what you did with our audience. I also want to thank our audience for joining us today. And then finally, I want to thank Intuitive for making this conversation possible. This has been Innovating for the Future of Surgery, leveraging data to drive actionable insights. Thank you very much for being part of the conversation.
Thank you.
Thank you, Molly.
Thank you.